Hey everybody, today we're going to be covering Chapter 25, going over drowning emergencies as well as diving emergencies and submersion. In this chapter we'll be covering emergencies that you will see that relate specifically to the water, as well as scuba and deep water emergencies. Um, Patients that are involved in any kind of submersion like emergency um, need care quickly. The reason being is the circumstances in which they receive these injuries could potentially expose medical personnel, the ones that are coming, to the risk of potential injury as well. So we want to make sure that not only do we have the proper skills needed to care for them, but the ability to recognize and avoid any hazards that may arise while you're on the scene. An adult can drown in just a few inches of water, and infants often drown in something as small as a 5-gallon bucket, with some others drowning in bathtubs and toilets. There are precautions that people can take that, for the most part, are pretty common sense, such as fencing around pools to prevent children from being able to run into them unsupervised. When they are near a lake, pool, or pond, or any kind of body of water and of any size, they should be under constant supervision. Not consuming alcohol while using water activities, and having on life preservers or life jackets when boating, so that way in case the boat tips, you have a life preserver on. Because what if you get knocked out? Avoid diving into shallow or unexplored bodies of water, and those with seizure disorders must be especially careful when in or around bodies of water. Drowning is an incident in which someone is submerged or immersed in a liquid that results in a primary respiratory impairment. Now, regardless of the outcome, whether the patient actually aspirates on water or not, it is termed a drowning. Many sources, however, continue to refer to the patient who survives a submersion event as a near drowning. The most common drowning location for children in less than 1 year of age is within the bathtub. 40% of deaths are between children younger than 5 years old, second highest among teenagers. With most of the drownings across all factors, males and alcohol is frequently involved. With the adult patient, we want to consider some conditions that may have led up to that patient becoming submerged. Could they have had a hypoglycemic emergency, a heart attack due to exertion, syncope or a seizure? Could it have been a suicide and the patient have been depressed? Could they have had a panic attack? Do they have arthritis, Parkinson's, or some other neuromuscular disorder that led to them to have poor body control? Do they become hypothermic? Or do they have some type of trauma involved, especially to the head or spine? Water sports also pose a hazard of submersion and drowning. The use of alcohol and drugs can impair judgment and lead to boating and other water-related accidents. Water skiing, jet skiing, and surfing can cause head or spinal trauma leading to submersion and drowning. And scuba diving accidents do occur because of exertion, inexperience, panic, and poor judgment from the diver that can also cause them to drown. Panic also is one of the main contributors to somebody who has um, a drowning event while diving or swimming, excuse me, because something goes wrong. Either they've swallowed water, they've become fatigued, currents, they become cold or entangled, and they start to panic. When they begin to panic, that now they're starting to breathe inefficiently. Well, that breathing inefficiently is now messing up their buoyancy. The way you breathe in water actually is assisting in you staying buoyant and being able to float. At this point, you become exhausted. You start drinking water. And you end up going into one or two ways. You either drown or you go into cardiac, or you drown and go into cardiac arrest. Quick rescue of a submerged patient from the water and early resuscitation are two of the most critical factors associated with better outcomes. No single individual characteristic has been found to predict survivability. Moderate body core hypothermia associated with submersion can provide a protective mechanism that reduces brain and other organ damage in children. However, most people do not become hypothermic quickly enough. As the person is submerged in water, he attempts to breathe, and he either does one of two things. He aspirates water, or his larynx spasms and causes him to suffocate. The most significant consequence of a drowning is the lack of ventilation while submerged, which thus leads to severe and prolonged hypoxia and the accumulation of carbon dioxide within the blood, which then can lead to severe acid buildup within the body. In dry drownings, laryngeal spasm prevents water from entering the lungs. When water does enter the lungs, the amount is small and it is usually absorbed into the bloodstream. The factor that has the greatest impact on the patient's prognosis is the duration of submersion and the consequent severity of hypoxia. If surfactant is washed out, the alveoli tend to collapse, a condition called atelectasis. The damage to alveolar capillary structures creates ventilation problems by decreasing functional lung volume, thus allowing fluid to leak around and into the alveoli, which then creates pulmonary edema. The alveolar capillary damage also begins to interfere with gas exchange, thus causing impairment of oxygenation of the blood and offloading of carbon dioxide from the blood. The patient who is breathing spontaneously but has signs or symptoms of respiratory distress or hypoxia can benefit dramatically from continuous positive airway pressure application. If CPAP is not available, consider early positive pressure ventilation with a bag valve mask device. Maximize the oxygen delivered to the patient by applying a non-rebreather mask at 15 liters per minute in the patient who has an adequate respiratory rate and tidal volume. If positive pressure ventilation is performed, be sure to connect oxygen to the ventilation device and deliver the highest possible concentration. Primary hypothermia can provide a role in protecting tissues against hypoxia. In other submersion patients, a secondary hypothermia can occur from heat loss through evaporation after the patient is removed from the water and resuscitation is attempted. Secondary hypothermia plays no role in protecting the patient against hypoxia and can actually cause further detrimental effects on patient outcome. Hypovolemia can occur also during and after the initial resuscitation period due to an increase in capillary permeability, producing hypotension. This can become especially evident when the patient's body begins to rewarm, causing the vessels to dilate. Dysrhythmias can also result due to the hypothermia and cardiac hypoxia, as well as from an increased amount of acid or disturbance in the balance of electrolytes in the blood. Some factors that can influence the seriousness of a patient's drowning would be like a persistent cough, because when you go to cough, you take that big deep breath and you're coughing it up. And as you're coughing, you're allowing more and more your lungs to open up more, so now you're able to get more water down further into your lungs. Apnea, altered mental status during submersion, because you're no longer able to control your own airway, drug or alcohol use because it could potentially subdue the gag reflex to help try to force the water out, as well as vomiting can influence the seriousness of drowning because you could potentially aspirate on your own vomit as well. You also want to look at the patient's past history to determine how it could have affected the drowning. Do they have a history of seizures, diabetes, or some type of neuromuscular disorder such as Parkinson's? What is the age of the patient? Were they hypothermic? And how, if they were in cardiac or respiratory arrest, how long was it? Patients who dive into water from a diving board, shore, poolside, boat, or dock often sustain injuries to the head and spine, along with fractures of the arms, legs, and ribs. You should always assume that a diver has sustained neck and spine injuries, even if the diver is still responsive. Now, this is pertaining to those diving into the water, not scuba divers. Do not let your desire to provide these simple life-saving measures overwhelm your judgment, because you can easily fall victim to the same hazard as the patient. Remember that water can conceal many hazards, such as holes, sharp drop-offs, and underwater entanglements such as fallen trees or wire fences that may not be visible from shore. In addition, currents in streams, rivers, or even storm drains can easily overpower the best swimmer. So do not ever attempt a water-based rescue unless you are properly trained in the rescue techniques, you yourself are a good swimmer, you have other rescuers there to assist, and you are wearing some type of flotation device. Make sure that you have a firm, solid footing and cannot slip into the water. Try to reach to the patient by holding out an object for him to grab. You can use an oar, branch, fishing pole, towel, shirt, or other strong object that won't break. And once the patient has grabbed the object, you can then pull him to shore. If the patient is responsive, but too far away to grasp an object you are holding, another way of reaching him is to throw something. Best thing to throw is a rope. Any EMS unit whose territory includes body of water should carry at least 100 feet of polypropylene rope in a throw bag that can be quickly deployed. Make sure you have firm, solid footing and cannot slip into the water. Tie a long rope or line to an object that floats and is heavy enough to throw, such as an inflatable ball or rescue ring. Throw the object underhand to the patient. Once he has grabbed the floating object, you can then pull him to shore. If the patient is unresponsive or out of reach with a line, you need to either row to him in a boat if one is immediately accessible, or go to him by wading out, swimming, or using some type of float board. So as you can see, were able to get a rescue ring, and they were able to throw it to the patient. So that way the patient could then grab onto it, and they can pull him then to shore. Don't ever become a patient yourself. Use a boat. Go to the patient, and then pull them in. If the swimmer might have been involved in a diving accident or have been struck by a boat, water skier, surfboard, or other object, you should suspect possible spinal injury. You should also suspect a spine injury, and any swimmer or diver who has been diving or using a water slide is suspected of being intoxicated or has evidence of traumatic injury. The goal is to support the back and stabilize the head and neck as other care is given. It's also important to stabilize the patient properly in the water and then remove him carefully from the water if possible, and if it does not pose a hazard for the rescuers. To assist with this goal of supporting the back and stabilizing the head, you can actually take a spine board out with you, because most of the ones that we have now, they are capable of floating. If the patient is in swift moving water or a body of water with waves, attempting to secure the patient to a backboard is not feasible and can likely put the rescuers in jeopardy. In this case, remove the patient from the water and apply spine motion restriction after they are removed. When the face of a human or any mammal is submerged in cold water, the larynx spasms, breathing is inhibited, the heart rate slows, and the blood vessels throughout most of the body constricts. Blood flow to the heart and brain, however, is maintained. In this way, oxygen is sent and used only where it is needed to immediately sustain life. The colder the water, the more oxygen is diverted to the heart and brain. This is what's called the mammalian diving reflex. Patients who have been submerged in cold water even after 30 minutes or longer in cardiac arrest can potentially be resuscitated. As a guideline, you should attempt resuscitation on any pulseless, non-breathing patient who has been submerged in cold water. If you do choose to go into the water to rescue a patient, be sure that you can swim, and do not put yourself in danger. Make sure to take appropriate standard precautions, because drowning patients often vomit. Decide if you need any additional assistance, such as a dry team to work on shore and a wet team to secure the patient in the water. Be aware that rescues in whitewater or swift water require specialized techniques and training. Go through your primary assessment. If the patient is found face down and a spine injury is suspected, work with a partner or partners, if possible, to carefully turn the patient over while maintaining manual inline stabilization. Suction any water, vomit, or secretions from their airway in a certain oral or nasal airway if the airway cannot be managed with manual maneuvers. Patients with spinal injury often do not breathe if they have a high cervical injury. Assess for any wounds to the chest that would seriously impede breathing. Any patient who has been submerged should receive a high concentration of oxygen because of the potential for pulmonary complications. If signs of severe hypoxia are present, consider placing the patient on CPAP. If breathing is inadequate, provide positive pressure ventilation with a BVM with supplemental oxygen. Check circulation to make sure the patient has a pulse and no life-threatening external bleeding that needs to be controlled. Patients with high spinal injuries affecting respirations who are found in respiratory distress or who are responsive or unresponsive are a high transport priority. With these patients, you want to perform a rapid secondary assessment if the patient has an altered mental status or is unresponsive. Also, look for any evidence of possible injury. If the patient is alert, obtain a history from the patient. If the patient has altered mental status, attempt to collect your history from relatives, friends, or bystanders that may be at the scene. For the water-related emergency patient, look for signs and symptoms of any injuries or medical problems, such as airway obstructions. Are they pulseless, soft tissue, or musculoskeletal injuries? Do they have any spinal or head injuries? Any external or signs of external or internal bleeding? Be aware that they may go into shock or be hypothermic. We want to categorize drowning patients as one of 4 categories. If they are asymptomatic, they are not displaying with any signs or symptoms of the drowning effect. If they are symptomatic, they usually have altered mental status, which can be slight confusion, altered vitals, respiratory distress or respiratory arrest, dyspnea, an SpO2 that is less than 94% with or without oxygen support. O2 reading can be also difficult to obtain or be low if the patient is hypothermic. Do they have a persistent cough? Are they hypothermic or wheezing? Do they have crackles upon auscultation of breath sounds? We also categorize them as cardiac arrest, in which they are apneic with no pulses, and obviously dead, in which there's rigor mortis independent lividity, which is purplish color caused by blood pooling within the lowest areas of the body. If you suspect that the patient has a spine injury, maintain inline stabilization and secure the patient to a backboard before removing from the water, if possible, and it does not jeopardize the rescuers. If you are able to get in to do a water rescue, if you find the patient face down, stabilize the head and neck with your arms, and then roll the patient over, supporting the back and stabilizing the head and neck. Once you've done that, while keeping the head and neck in line with the spinal column, slide a long backboard under the patient, securing the torso and legs to the backboard with straps. You can then apply your C-collar and then float the board to poolside so that way you can get them out. Once you get them to the poolside, there should be somebody on land also to help you move the patient out. If you do not suspect spine injury, place the patient on his or her left side so that water, vomit, and secretions can drain from the upper airway. Also, be sure that you have suction ready and prepared, as these patients often have water in their airways and tend to vomit because of the water that has been swallowed. If the patient is in respiratory arrest or is not breathing adequately, establish your airway and begin positive pressure ventilations with supplemental oxygen as rapidly as you can. Once you've determined that there are no foreign objects within the airway, provide ventilations with increasing force until you see the patient's chest rise with compressions of the bag valve device. If the patient is breathing spontaneously and inadequately, apply high flow oxygen to maintain an oxygen saturation of at least greater than 94. Apply a non-rebreather at a rate of 15 liters and consider CPAP in those that are exhibiting respiratory distress, O2 sat less than 94, and spontaneously breathing. If they are pulseless and apneic, begin CPR and apply your AED and follow AED protocol. When gastric distension reaches the point at which it interferes with the capability to ventilate your patient, place them on their side, and with suction immediately available, place your hand over the epigastric area of the abdomen and apply firm pressure to relieve the distension. Do not apply the Heimlich as a routine maneuver in the submersion or drowning patient, as it can lead to vomiting and aspiration. Manage any other medical or trauma conditions that you might find with a drowning event. Transport the patient as quickly as possible, continuing resuscitative measures during your transport. Approximately 15% of all drowning-related deaths result from some type of secondary complications. During transport, you should keep the patient warm and continue to provide high concentration oxygen. Secondary complications can arise up to 72 hours after the incident. Be alert for signs the patient is deteriorating into respiratory or cardiac arrest, especially if you previously resuscitated the patient. So for unstable patients, we reassess how often? Right, every 5 minutes. For stable patients? Correct, every 15 minutes. You may not practice as an EMT in or around oceans, but accidents involving diving can occur anywhere. Many people dive in quarries, lakes, rivers, and caves. Dysbaryism is a medical condition that results from the effects on the body of changes in ambient pressure. The pressure changes occur when a person descends um, in water or ascends in altitude. Recreational and commercial divers, when descending into depths of water, experience a drastic increase of pressure on the body. This pressure affects only the compressible structures and substances within the body. The gas contained within the organs, dissolved in the blood, and found in hollow spaces is compressible and is affected by changes in pressure. If the diver is breathing in compressed air at a depth where there is a higher pressure on the body, and then suddenly ascends, the volume of air in the lungs rapidly expands because of the decrease in pressure as the diver ascends. This can then lead to barotrauma, or rupture of the alveoli and other lung structures. That's why it's important for divers as they are surfacing to be exhaling. As the diver also goes deeper underwater and the pressure of the inhaled nitrogen increase, the nitrogen begins to dissolve into the blood. Nitrogen in the blood affects the electrical properties of the brain and could potentially produce what's called nitrogen narcosis, which affects similar to an anesthetic. With Henry's law, when a diver descends and pressure increases, the nitrogen inhaled tends to dissolve into the body's liquids, mainly the blood plasma. It then also begins to dissolve into and accumulate into the body fat and tissues. Um, if the diver then ascends too quickly, the dissolved nitrogen returns to a gaseous state where it is still dissolved, causing bubbles to form in the blood and tissues. With Charles' law, what it states is as gases are heated, they begin to expand. Well, as a diver goes down and they're descending, the water gets colder and colder and colder. Thus, those gases begin to contract. And as the diver ascends, the temperature increases and causing these gases to potentially expand. Decompression sickness, also known as diver's disease, the Benz, or Cassian disease, is a condition caused by dissolved gases coming out of solution to form bubbles inside the body on depressurization. These bubbles can cause coagulation of blood to occur. In response, the vessels and surrounding tissues release substances as they would in an allergic reaction. These substances produce signs and symptoms similar to those of an allergic reaction. Factors that could potentially increase the risk of a patient developing decompression sickness is flying or going to a high altitude too soon after a dive within 12 to 24 hours, failure to take the necessary safety stops, diving at deep depths for too long, repeated dives on the same day, and inadequate surface intervals, which allows nitrogen to accumulate during a sequence of dives. Physical characteristics that could predispose an individual to DCS is poor physical condition, dehydration, fatigue, pre-existing musculoskeletal injuries, and the patient's age, as well as obesity. Environmental factors that predispose to decompression sickness includes cold water, heated diving suits, rough seas, and heavy work. Now, there are three types of decompression sickness. The pain characteristically associated with decompression sickness has given this disorder its nickname, the bends. It usually results from a diver ascending too rapidly from a deep, prolonged dive. As noted earlier, gases, typically nitrogen, forms bubbles within the blood and tissues, thus causing obstruction of vessels and compression and stretching of tissue. The onset of DCS can occur up to 72 hours following the dive. In type 1 DCS, pain is the number one hallmark symptom of DCS. It is seen in approximately 70 to 85% of patients with type 1 DCS. The pain is typically a dull, achy, throbbing-like pain, usually within the joints or tendons. It can also be in other tissue. The shoulder is the joint in which the pain is most commonly experienced. The pain typically begins as mild or not severe, and then gradually intensifies. Many divers initially think that the pain they experience early on from DCS is due to a pulled muscle or muscle exertion, so they don't go get treatment for that pain. Type 2 DCS is more severe than Type 1. The patient experiences more significant signs and symptoms, however they can be diverse. The onset of the signs and symptoms is usually immediate, but it could be delayed for up to 36 hours post-incident. They may have headaches, visual disturbances, nausea or vomiting, nervous system irregularities, lower back pain that progresses to paresis, paralysis, numbness, or tingling, loss of sphincter control, and girdle pain from spinal cord effects, the most common site for type 2 DCS. Within type 2 DCS, you can also have two subsets. You have circulatory system symptoms and respiratory system symptoms. Within the respiratory system, you may have substernal burning sensation, non-productive cough. Respiratory signs and symptoms are known as the chokes. The symptoms can begin up to 12 hours following the dive and last up to 48 hours. Within the circulatory systems, your patient may show with signs and symptoms that mimic hypovolemic shock, primarily tachycardia and hypotension, resulting from fluid shifting from intravascular to extravascular. You may also have the formation of a thrombus from activation of the blood coagulation system. When performing an assessment on the patient, you should be looking for these signs and symptoms for patients with decompression sickness: fatigue, pallor of the tongue, pupillary changes, bloody sputum, nasal flaring and retractions, tachypnea, crackles, SpO2 less than 94, seizures, neuromuscular irregularities, edema, joint pain including a decreased range of motion. When assessing these patients, you want to ask the following questions. Where did you dive? What was the deepest dive and for how long? What was the rate of ascent? And what has the patient done since the dive? Something that can help you in assessing these patients is divers are supposed to maintain a dive log. So if you're suspecting that this could potentially be a dive-related emergency, ask them to see their dive log. Live log will have all of this information that you need, pending it's a responsible diver and is maintaining their log. You also want to know what the patient did 72 hours before the dive. Did the patient do any work during the dive? And what gases were they used? Because we I say we because I dive also, but you might have some divers that breathe with just oxygen, and some that even breathe with what's called nitrox, which is a mixture of nitrogen and oxygen. What was the patient's physical condition before, during, and after the dive? And was any first aid provided, such as oxygen, positioning, or medications? The third type of decompression sickness is arterial gas embolism, or AGE. AGE is the blockage of blood vessels due to an air bubble or clusters of air bubbles. The blockage interferes with the perfusion of body tissues with oxygen and nutrients normally supplied by the blood. This is caused when the diver ascends too rapidly while holding his or her breath, thus causing the air in the lungs to rapidly expand, rupturing the alveoli and damaging adjacent blood vessels. As a result, air bubbles are now able to enter the bloodstream. The signs and symptoms of air embolism have a rapid onset, often appearing within 15 minutes of a diver's surfacing. They'll present with an itchy, blotchy, mottled skin color, chest pain, severe, deep aching pain within the muscles, joints, and tendons, blurred vision, partial deafness, unsteady gait, weakness or numbness to one side of the body, frothy blood in the nose or mouth, crepitus and swelling within the neck, behavioral changes, coma, and or cardiac or respiratory arrest. Divers with upper respiratory infection or allergies are at increased risk of barotrauma. And what barotrauma is when pressure becomes too great within the body's air-filled cavities, such as the sinuses or middle ear. That's why it's imperative for divers to pressurize as they are going up or down. Signs and symptoms of barotrauma may be mild to severe pain within the affected area, clear or bloody discharge from the nose or ears, dizziness, nausea, or disorientation. Patients suffering from barotrauma must be cared for at a medical facility immediately to prevent permanent deafness, residual dizziness, or the inability to dive in the future. If any suspected spinal injury exists, take the necessary spine motion restriction precautions. Keep your patient in a supine position if spinal injury is suspected or if the patient is alert. If the patient does not have a suspected spinal injury and has altered mental status, place the patient in a lateral recumbent position. Open their airway and assess for adequate breathing. If breathing is adequate, administer oxygen via non-rebreather at 15 liters per minute, even if their SpO2 is greater than 94. Oxygen is very critical in diving emergencies because it reduces the size of the nitrogen bubbles and improves circulation. Be sure to document the exact time of oxygen delivery. And if the tidal volume or respiratory rate is inadequate, begin positive pressure ventilation with oxygen equipped. If they are unresponsive and not breathing, initiate CPR and apply an AED. Transport the patient immediately. If it is a diving emergency, try to obtain the patient's diving log and transport it with him to the hospital. Contact medical direction to consider transport to a facility with a hyperbaric oxygen chamber. Now, within our areas, we don't have a hyperbaric oxygen chamber. The nearest one that is designed for these purposes would be down in Pensacola, Panama City, along the Gulf Coast region. Alright guys, that concludes it for today. Make sure that you are doing your Brady Labs. If you have any questions that may arise, be sure to either email me or send me a message in Remind, or write it down and you can ask it next time we are in class. Otherwise, y'all have a good rest of your day, and I will see y'all next time.